Hello, everyone. It's a pleasure to be here. My name is Dalva Poyares, and I am a professor at Psychobiology Department, Sleep Division, from our dear Federal University of São Paulo. And it's my pleasure to introduce these professionals presenting data on sleep epidemiology. This symposium celebrates the launching of Sleep Epidemiology Satellite Center, Brazil, Stanford. I would like to thank Federal University of São Paulo team for their support and Dr. Pires, who helped with the organization. Dr. Tufik, Sergio Tufik, was the one who firstly conceived the idea of having epidemiological studies starting in 1986. He's the main mentor of most of us. And for that, I will leave here our appreciation. We are lucky to have here his son, who I will introduce soon, and Dr. Ohayon, who is the head of the Sleep Epidemiology Center at Stanford University, and was a pioneer of using artificial intelligence in epidemiological studies when no one even heard of it. Dr. Ohayon is one of the most distinguished epidemiologists and researchers in the field of sleep. I thank Dr. Ohayon for being here with us, and I will tell you the audience's secret. Dr. Ohayon is really short sleeper, and contrary to all literature expectations, he's doing great, and even with his little sleep habits. I will now present the speakers for this symposium. Following Dr. Ohayon's introduction, I will introduce Dr. Ulf Kallweit, who is a professor at University Witten in Germany. Thank you, Professor Kallweit. Professor Gabriel Pires, who is in the left of my screen, who was a professor at Santa Casa University, and he's now a researcher in São Paulo Sleep Institute. Dr. Sergio Brasil Tufik, who I am very happy to have here. Besides being Sergio Tufik's son, he is a researcher at São Paulo Sleep Institute, speaking directly from Yale University. The dearest Professor Malcolm von Chance, who is very well known among us, and he's a professor at Northumbria University in the UK, United Kingdom, and has collaborated in several studies with the Brazilians. You will hear from him soon. Finally, our also dear professor at University of São Paulo and chief of hypertension division, Luciano Drager, who will be with us soon. After each presentation, we will have a few minutes for questions, and I will ask you to write them in your YouTube chat, and Dr. Pires will be happy to address them to the speakers, and he will take in charge also to translate. Feel free to write the questions in Portuguese. At the end of the sessions, we will discuss some perspectives and wrap up. I hope you enjoy, and I leave you with Dr. Ohayon. Thank you.
Thank you, Dalva. It's a pleasure to be there with all of you. It's many, many years that I know each of you, practically 20 years. That is doing a lot of time, Dalva. And my pleasure is always the same when I am with my Brazilian colleagues. We did the first study of epidemiology something like in 2003, 2004, and we were developing at the period a study with the general population. So my goal presently is to be there to inaugurate the new satellite center of Stanford, and I have the pleasure to present you the director of the satellite center, that is Professor Poyares. Congratulations. And I wanted also to speak a little about where we are presently with sleep epidemiology in our study through the world. So what is happening presently is that sleep epidemiology is raising a little attention. It's paradoxical because epidemiology is one of the field, the basic field that we need for sleep. But unfortunately, this was practically never developed. Until now, the only sleep epidemiology center in the world is the one of Stanford. It doesn't exist another center in the world inside of an university officially recognized. So this situation has pushed the researcher in some reserve, and until now, a big confusion between clinical estimation and what is really prevalence in the general population. We try presently to avoid this problem inside of our studies, but I am trying to push a little more through publication, through new journal like the Journal of Elsevier Sleep Epidemiology, to push a little more this science of epidemiology with sleep. Sleep is not a pathology. We all sleep 1/3 of our life. So let me say to you, until now, the only problem with sleep was we were interested by sleep because of pathology. But sleep is first a normal phenomenon. How we can forget that the people have not only a problem to go to sleep, but sometimes they have a problem because they go too much to sleep. And that is the introduction to only my little introduction that I wanted to tell you about what Stanford Sleep Epidemiology is doing. So we have created, Ulf and myself, a consortium that the name is the WAKE Consortium. This WAKE Consortium is about hypersomnolence and sleep disorder, much more importantly, about the vigilance of the population. We have presently a general problem in the general population that is the people are sleepy. They are sleepy not because they have a lack of sleep, but also because they become obese, because they have a hygiene of life that is not allowing them to sleep in a good condition, because the condition of the modern world with all this computer, all this blue light are producing people that are highly disturbed in their circadian rhythm. So let me speak about a little the WAKE Consortium. So the WAKE Consortium is based on a tool that is an artificial intelligence tool that we use since practically 20 years, that was conceived in the early 1980s in collaboration at the period with Apple. That is a paradoxical thing, and was continuously developed until practically 5 years when it became a tool in the cloud. So the key role in and technology of this new consortium, we have Professor Kallweit, that is vice chair of the consortium, the Stanford Sleep Epidemiology Research Center for Research and Operation, the Eval Research Institute that is in charge of the artificial tool for investigation. And we have a collaborative network with Stanford Satellite Sleep Epidemiology Center, 12 presently, and collaborative center, hospital, clinic, and other, presently 64. So this group has a focus that is on vigilance. And it's important to know that sleep, again, include vigilance. The people are forgetting we are sleeping to be vigilant at the end and with a good quality of vigilance. Unfortunately, this is forgotten completely, and the people are really focusing too much on sleep per se. But sleep vigilance is only two faces of the same piece. It's only something very simple, sleep vigilance. And is why we have tried to focus on hypersomnia, hypersomnolence, idiopathic hypersomnia, narcolepsy type 1 and type 2, all symptoms of hypersomnia, and prevalence predictive factor, medical psychiatric condition that can push the people inside of this kind of problem. So, in fact, we search not only the people that have the pathology, but also the people around that can have less symptoms and less manifestation of this kind of pathology. So we are phenotyping family member, identification, genetic identification and immunologic determinant, record of all the immunological events, assessments with Adenfer sleep eval on a longitudinal study with follow-up evaluation. And what we expect is that the number of first subject estimated 10,000, and the number of family expected estimated to be between 40,000 and 60,000. Don't forget that this disorder on which we work are part of what we call the orphan disease. So I will only introduce a little the collaborative center. Here you have some details. The recruitment is done through satellite center, collaboration with university, clinics, private center. The geolocation of the collaborative center actually totally involved in the study. In USA, 14 centers, in Canada, 2 centers, in South America, 5 centers, in Europe, 7 centers, and in Asia, 3 centers. So again, I will not go through the detail. This is a project overview, as you see, is really a longitudinal study. And our goal is to have the same subject from the beginning, from wave 1 to wave 10, 15 in the future, is that it will be a true longitudinal study identified by subject. So we have big expectation. We hope that very soon we will be able to publish on these results. All of that to tell you that we are really very excited by this new consortium. And by the way, I want to introduce now Professor Ulf Kallweit, that is from the Witten Herdecke University of Germany. Professor Kallweit is the vice chair, again, of the International Wake Consortium. And he is also the founder, head of the Center for Narcolepsy and CNS Hypersomnia. He is the head of the Sleep and Neuroimmunology Clinic. And his main interest and area of research is narcolepsy and hypersomnia and multiple sclerosis. He has authored a lot of papers in a big journal. Only let me cite one in Nature that you know everyone about immunology. And Dr. Kallweit has received several awards and prizes. And he has, for example, received the prestigious research prize in neuroscience from Pfizer Foundation. Professor Kallweit, is your turn. Please give us the pleasure of your lecture. Thank you.
Dear Dr. Ohayon, dear Maurice, thank you so much for this very kind introduction. Dear organizers, dear Dr. Poyares, in particular, also thank you very much to you for this invitation. And it's really a great pleasure and honor to be here, one of the first speakers in this new event. And also it's a great pleasure to be part of this consortium. Thank you very much also, Maurice, for this. So I actually would like to start, as it has been presented already, about the topic of narcolepsy. And I think, as you all know, narcolepsy is in many ways probably a model for sleep disorders, the functioning of sleep. Maybe also we can discuss about the epidemiology of sleep here. But my part will be in particular to discuss the management. And I selected the title to discuss pharmacological therapy and beyond. And actually, this is what I would like to discuss with you today and to present you. In my first part, I would like to speak about more than sleepiness or what really matters. Then I would like to speak about before pharmacological treatment, self-care and behavior therapies, and then about the symptomatic medication, the current medication, and beyond, and an outlook what may come in the future soon. So let me start with the first part, more than sleepiness or what really matters. If we think about the symptoms of narcolepsy, most of us have learned and read in the books that the symptoms of narcolepsy are excessive daytime sleepiness, are cataplexy, sleep-related hallucinations, sleep paralysis, and maybe also disturbed nocturnal sleep. This is a very, let's say, closed concept of the symptoms of narcolepsy. If we look in data which are available, please, the next slide, then you can see that if you ask the patients, what are the symptoms you experience, then you see, of course, it is excessive daytime sleepiness mentioned here, but you see that also in a large proportion of patients, difficulties in thinking, concentration, attention deficits, irritability are mentioned. And in a recent study from the Netherlands, the key or the main present symptoms at the baseline are EDS, but also lack of energy, difficulties in concentration, and difficulties in memories. So, saying this, you see that actually the spectrum of symptoms of narcolepsy, it's much broader than we probably have in mind. The next slide, please. And I try to give you some kind of figure for this. So to say, we have EDS, cataplexy, of course, but we also have the mentioned concentration and memory deficits. We have headache, we have depression, and other aspects. And if we see how we address them, actually, this is very simple. We use, for EDS, we use an ESS, we use maybe MSLT. For cataplexy, we use sleep diaries. And so many other aspects are not even addressed at all, neither in clinical trials and often also not in our clinical daily practice. So if we continue, yes, this is just the way how we address these kind of items. Please, the next. So, and having this broad spectrum of symptoms, we may think what is really important for the patient and what really matters. Is it important to have a change in the ESS of 2 points? If we ask the patients here, we see that performing duties like cooking or cleaning is very important for many people, or just to be able to socialize with friends. And this is actually what in the recent European guidelines has been mentioned also by the patients themselves. So the patient themselves suggested the doctors, the physicians, should look outside of EDS and cataplexy. They should focus on practical issues and really to check what is a practical concern of them. And they request an individualized management. So this is nothing from physicians. This is the concept also the patients are requiring from you, not to look on an ESS value, but to solve a practical problem they have. And this is, I think we should change our view of addressing these aspects. Please, the next one. So if we really address these points, we should first discuss about non-pharmacological aspects, self-care and behavioral strategies. So the first part, you are probably very well aware of this, but I also realized that so many patients are not very well informed about their disease. Of course, they look at the internet, they search some platforms, have Facebook discussions with people, but the information they have is probably not appropriate. And to my opinion, this is the first step and first part of also of the management to inform them appropriately about the course, about the prognosis, and others. You should support them with additional sources of information and have self-help groups and concerning websites, etc. The second part, next slide, yes, is actually very well taking daytime naps. And I realized that often it is said, well, this is just by the way, you should also schedule napping. But if you take this recommendation very well and explain it to the patients, it is really can be a game changer, and it is essential for the management of these patients. Besides of taking daytime naps, the regular daytime structure is important. Staying active, there are some data indicating that really a physical active person with narcolepsy is also more awake and also having less cataplexy. When talking about cataplexy, please the next, we see that it is important also to discuss with the patient cataplexy triggering situations, because in a recent study we have performed, we see that 2/3 of the patients really tend to avoid cataplexy situations causing cataplexy. So, and we see that these avoiding behaviors are associated with a decreased physical functioning and also with depression. So it should not be to discuss with the patients about avoiding cataplexy situations, but to consider that how to handle and how to deal with this. The next. We should also consider, of course, how much caffeine to use and how much potential sedating medication. And in the last years, and also with a lot of experience, we see that particular maybe a low-carb diet is helpful also for wakefulness in these patients. The third part of the management is also in some patients at least necessary to have some kind of cognitive behavioral therapies, which addresses in particular coping with a chronic disorder, helping to establish a daily structure, and also addressing psychiatric comorbidities. And the patient support group can be also very helpful, and I'm also very glad that very recently in Europe, a joint European Narcolepsy Alliance has been established called ENAP. What, of course, in the last years, I think almost everybody has developed some kind of an application. We also did so with some colleagues together from the University of Dortmund. This is the narcolepsy app, which is currently in a study. And we see that this is also a potential aim to help patients to manage their disease. And in some countries, And this is the next part of this. We also see certain rehabilitation programs, which can be done in-house or can be done ambulatory. I'm aware of an ambulatory program in Italy. In Germany, we even have the option to see these patients in-house for 3 or 4 weeks and to specifically address narcolepsy with specific programs, specific therapists, and to discuss also within them their disease. So, having said this, I would like to give you an example, very short example of one of my patients, which has described this course of the disease. So, typical type 1 narcolepsy patient, diagnosed very clearly for narcolepsy. And what he described, the next, is these symptoms, so chronic sleepiness, involuntary napping, when he was 15, brain fog, cataplexy, very severe every day. He's currently unemployed. And from the physicians that have seen him, the treatment was, okay, you should schedule some napping and modafinil and venlafaxine as treatment. What happened to this patient? When he came to us, he mentioned, no, I just fall asleep as it occurs. I did not take venlafaxine because I read it's an antidepressant and I was afraid to become addicted, and I don't want to become crazy because of taking an antidepressant. Modafinil was felt to be helpful, but he didn't take it so frequently. He still was not able to work, he gained weight, and his girlfriend, they were thinking about having children, but she was afraid that this was a genetic disease, and so she did not want to have children. So what did we do with this patient? The next one, we only discussed about the things I have shown to you before, about non-pharmacological aspects. We discussed with him why it is important to schedule nap at least once during noon, and he did so. The next part is to explain the patient why venlafaxine is helpful for him, not as an antidepressant, but to improve cataplexy. Why maybe a little bit adaptation of the medication also was helpful for him. And this also resulted in an improvement of his workability. And the next was also explaining him that low carb could be useful. He stopped eating sweets and stopped weight gain, explaining his girlfriend about that narcolepsy is not to be afraid that all children are going to have narcolepsy or something. So it's just explaining to them. Overall, just by have a better information, explanation, this patient improved a lot. So to summarize this first part, I would like to mention, so you have seen that narcolepsy is more than EDS and more than cataplexy, and often these are the aspects of concentration or other daily activities that needs to be addressed by the physician. And you see also that self-care and behavioral strategies are helpful and safe and should be actually the basis of the treatment and not just an addition to the medication. Coming now to the current medication and outlook, I would like to start with a short overview, because I think it's important to understand where we treat and where we maybe in the future can treat. So the next, please. We believe that narcolepsy is a disorder based upon genetic factors, environmental factors involving the immune system, causing an orexin deficiency. We also know that there seems to be some kind of histamine dysregulation, and we believe that this orexin deficiency in particular is responsible as the cause of the symptoms of narcolepsy. Continue, please. Next. So we currently have some biomarkers here. You're aware of this, the measurement of orexin in the cerebrospinal fluid, and we have the sleep onset REM periods. And maybe in the future, we have additional biomarkers we can use, and this may also help us to identify potential new therapeutic items to address. And as it had been mentioned, we see some changes in the immune system. We identified autoreactive T cells in narcolepsy against hypocretin. There are some recent publications on imaging indicating or important for potential differential diagnosis of this disease. And I'm happy to have so many experts today here. The next is, of course, artificial intelligence, which can be very helpful, probably also to identify different aspects. I just selected one recent publication from the European Narcolepsy Network, which indicated that potentially the sleep duration between type 1 and type 2 within the MSLT test may be different in type 1 and type 2 narcolepsy. So having this overview, where do we currently treat with our medication? We are treating symptoms. This is what we are currently doing. And if you continue, the next, we try to collect all the information available about the current treatment in a guideline. The last European guideline, at least, has been published in 2006 before. And we put together this guideline and recommendation on the management of narcolepsy in adults and children. And I also would like to address that the US colleagues, Gabriel Marsky, as first author, also has published a similar statement on the management of narcolepsy. So this guideline included different PICOs, patient intervention comparator outcomes. I'm not going too much into details, but I just want to mention that in this guideline, besides of the pharmacological therapy, other aspects, non-pharmacological comorbidities and others have been mentioned. And where no guideline criteria could be fulfilled, expert opinions on special conditions, and also, as I've addressed before, the patient's needs and view has been presented. The next. So when we treat the different symptoms, actually, I'm coming back to the overview I've shown to you. What kind of wake-promoting agents we are currently using, and we are using them for EDS, are mentioned here. We have other components which are mainly used for cataplexy, and only one approved and maybe also recommended for some kind of sleep-promoting agent. The next, please. I believe you're very well aware of most of these compounds, and I just would like to very shortly address a few recent data that may be important for you. For sodium oxybate, you're very well aware that this has an improvement on cataplexy and on the disturbed nocturnal sleep in adults. But some years ago, the group, also from Giuseppe Plazzi from Italy, published data on children. And you see here also in children that sodium oxybate has a good impact on cataplexy and on EDS. And this also results in an approval for the use of children at the age from 7 in Europe. The next component, which is more used since 2015, I think, is pitolisant, an inverse histamine receptor 3 agonist. And for this component, it has been shown to be efficacious on sleepiness and on cataplexy too. And in also real-world data now, after 1 year, and other data also indicate this, it has been shown that it also improves other symptoms of narcolepsy, such as hallucinations or sleep paralysis. The third one is solriamfetol. This is a quite new compound, also used in particular for the improvement of sleepiness. It is a norepinephrine dopamine reuptake inhibitor, and studies have been shown to be efficacious on ESS and on MWT. There are very few studies combining therapies. And I believe most of you in your daily practice and clinical practice are often combining different medications. Unfortunately, we have very few data. The one publication indicated that the use of a combination may be more efficacious than every individual compound by itself. So putting this together in the European guidelines, but I may say this is quite similar to what the US colleagues also have published. We have certain recommendations for the use of EDS as indicated here. I may also say that in particular drugs used modafinil for many, many years is a very efficacious component, as also the others mentioned here. And for cataplexy, for example, also drugs like clomipramine or venlafaxine, although having very few data, most of our experts believe that, see that this is an efficacious treatment. We also tried to put this in a clinical pathway where we decided between the occurring symptoms or symptomatology and made certain recommendations which components may be used as first or second line options. So this is what we are currently doing, and you may be interested also what is coming maybe next. And I have mentioned that there is an orexin deficiency, and I think for 20 years it is logical that people are considering, okay, so there's a deficiency, so we just replace this. And it has taken some time until some compounds could have been developed. And the other aspect is, can we modulate at a very early stage the disease if we start with some kind of immune medication here? The next slide, please. So also looking also in the guidelines, we looked very closely, what do we know about potentially disease-modifying treatments? Immunoglobulins, which probably have been used for many years, plasmapheresis, steroids, and also monoclonal antibodies. All over, the data available are very limited, often only case reports or case series. However, these components potentially have severe side effects, and so the decision was to say we cannot recommend these medications at this point because we do not see positive signs on efficacy, but a potential harm. Also, a very recent patient, this is a case report from the United States also, where a very new patient has been treated first with immunoglobulins and then with natalizumab, did not indicate a change on the hypocreatine levels and also on a clinical improvement. So overall, the available disease-modifying treatments do not seem to be recommendable. The next. I mentioned that a lot of work currently is done on the orexin system, and in both ways. On the one hand, to have orexin receptor agonists to increase wakefulness. Also, other compounds are working to be working as antagonists for improve of sleep. So one of the companies working very intensively here is Takeda, and Takeda has also published some first clinical trials, very early trials, indicating that this concept here may be efficacious. The next one. So as mentioned, this is not the only company working on the orexin system. Also, there's additional work done on the histamine 3 receptor agonists, additional ones. I mentioned pitolisant as the first one. Now there's additional work. You're probably aware of different formulations of oxybate taking at night, and also some compounds which has been used in the past. I remember of using reboxetine several years ago, and some of my colleagues also remember using mazindol before. And so these compounds also are under investigation again, sometimes a little bit modulated, or but based upon these drugs. Very, very recently, and I may comment on this, it can be that we start to change a little bit our concept, because until now we believe that the orexin producing cells are not working anymore. There's a gliosis of these cells. In 2018, Tanikal and colleagues described that in patients with addiction, more orexin producing cells are found. And they made an animal study with mice, where mice were indicated to lose their orexin producing cells, and one group of them were treated with morphine. And in these mice, again, more orexin producing cells than were found. So this was maybe the first time to consider, is it possible that the cells are not really dead, but only are silenced? And I may just show you one of very, very, very recent, it's not even a publication, it has been presented at some congresses, and it's currently under review from the group of Mehdi Tafti in Lausanne. He has done some very nice studies in mice, in zebrafish, and also from the blood in humans, and sees that in narcoleptic patients, there seems to be some kind of hypomethylation of the hypocretin receptor promoter, indicating that the orexin cells are potentially only silenced by hypomethylation. This, as I've mentioned, very early, it's not even finally published, but it seems to open up a new pathway for us to understand the disease and also potentially to treat the disease. And having said this, I may summarize this part also. I think you have seen already about the extensive symptomatic treatment options which are available. I try to indicate what may be the future of treatments, and again would like to conclude that the importance of considering and addressing the individual symptoms of the patients and their limitations, and that we are going towards an individualized therapy. Thank you very much.
Very nice presentation, Dr. Ulf. And I just want to remind our audience that we can receive questions through our YouTube chat. And we just received one regarding your presentation. It's a question by Dr. Daniela Rosa, which she is a professor of immunology here at the Federal University of São Paulo. And she asked you to, if you could please comment a little bit more on the use of immunotherapy in narcolepsy.
Yes, thank you very much for this question. So the potential concept is that we see that when symptoms of narcolepsy occur, according to animal data, about 50% of the orexin-producing neurons are not working anymore or dead. So it seems that we are currently already in a process where continuously orexin-producing cell neurons are dying or not working anymore. And this process in some patients seems to underwent within weeks or months, and in other patients it may take even years. So, but whenever when the patient are describing symptoms, and usually when it comes to the diagnosis, which often unfortunately is years later, it seems that we are too late to somehow be able to catch the immune system to destroy the neurons. So all trials, even in very early patients diagnosed, as mentioned in steroids or other things, were not positive. So it seems for many of us that we are too late, or maybe we are not addressing well enough the item, or not specifically enough. But potentially we are too late, and therefore it seems so important to identify biomarkers which may indicate us in an earlier stage of the disease, and then we could consider again maybe to make some immune modulatory or suppressive treatments.
Very, very interesting, Dr. Rolf. I thank you very much for your presentation.
Thank you.
And again, just a few words in Portuguese. Para a nossa audiência, para quem estiver nos ouvindo aqui, lembrem que o chat do YouTube está disponível para todos. E fiquem à vontade para colocar perguntas em português também, que quando for o caso, nós podemos traduzir para os palestrantes. So now going back to English, the excellent lecture by Dr. Rolf closes the first section of our symposium. And now we're about to move to the second session, in which we discuss a little bit of the Brazilian efforts on sleep epidemiology, starting with the EPISONO cohort or the EPISONO study. So in this section, the EPISONO section encompasses 3 lectures, the first by myself, then following we will have a lecture by Dr. Sergio Tufik, and then Dr. Dalva Poyares. Actually, Dalva, then Sergio. So I'll be talking with you regarding the theoretical aspects of the EPISONO study. So giving some introduction to you about the history of why we're doing this study for all these decades, the achievements, what have we reached so far, and what are the future directions of the EPISONO. EPISONO is the acronym for this study, which comes from the Portuguese composition of words for the São Paulo Epidemiological Sleep Study. So we can say safely that EPISONO is one of the biggest, the largest polysomnography-based epidemiological sleep studies worldwide. Certainly not the only one, but among the largest. You will see that in a moment. But for some solid start, we can say the first edition was performed in 1987, and then we've been trying to perform new editions of EPISONO, not a cohort, but new cross-sectional editions every decade. So the first edition was in 87, then in 1995, then in 2007, and a last edition in 2019, which is still under analysis, and first results should be released soon. The third edition, performed in 2007, was the one that was transformed into a cohort. So we had a follow-up of that group of people in 2015. So nowadays, you can say EPISONO grows with new cross-sectional studies every decade and new waves of the third edition every 8 to 10 years. We're planning a new wave for 3 or 4 years in the future. So I would like to give some introduction on why we're performing these studies. And to introduce so, I would like to introduce who we are, what is the Sleep Institute, and why do we think it is important to address sleep epidemiology in a population level in the city of São Paulo. So the Sleep Institute is actually, we're still working even in the pandemic time. So we were founded in 1992, and we are nowadays in Brazil the reference sleep center in terms of research, diagnosis, and treatment of sleep. We can say that not only because of our expertise, but also because of our broadness of scope and how large is our facilities here in São Paulo. We have over 70 polysomnographies being performed per day. We have actually 83 polysomnography beds available. Among all of these polysomnography beds, 13 are exclusively devoted to research. So with this facility, we can perform the studies like EPISONO, like that large epidemiological sleep study. We have a smaller unit, which we call Napoleon unit, and that comes from the street, Napoleon Street, where it is located, in which we have 13 beds for research purposes only. And we also have this Marseillais unit, again, because that's located in the Marseillais Street. That's some relation with France here. You see Napoleon and Marseillais as the streets where we are located. But in this building, which belongs to a philanthropic research supporting agency named AFIP, which the Sleep Institute belongs to, we're located in this building with 4 floors, in which we have all these polysomnography rooms and also the rooms for clinical appointments and so on. So we do have a good and large facility to promote studies and also clinical appointments and treatment and everything we need to provide good sleep medicine and sleep care to our population in the city of São Paulo, in a way that we can say safely we are the largest sleep medicine center. And we should understand large in terms of size, not quality. We have quality, high quality sleep research every corner in the world. But I guess considering you have 81 or 80 something beds per day, that's indeed big. Such a big institute was founded by our president, Dr. Sergio Tufik, which was the one who was the promoter of the EPISONO trial, the EPISONO study. So he founded the Sleep Institute, and he's our research leader, the team leader, so to say, and the one who has been in charge of our publication output, so to say, which has been growing since the 70s and reaching a peak more or less about 10 years ago, right when we finished the 3rd edition of EPISONO, and when we also had a very, very interesting research grant from Brazilian agencies. So you see that we had this peak in 2012 to 14. But we have been growing since then with EPISONO 2007, as I mentioned, and the CEPID grant. So summing things up, we live in a large city. São Paulo has 11 million inhabitants. So we're as a city are bigger than several European countries or several American states. And that's the reason why we have such a large study for a single city. So EPISONO was thought as a research project to be carried out every 10 years to verify the quality and the quality of sleep and sleep disorders in the city of São Paulo. The first edition of it was, as I mentioned, in 87. We are growing every 10 years, and we're planning new waves every 80 years. This one was planned to 2022, but as you know, we're undergoing a pandemic still, so that will be postponed maybe to 2024 or something like that. But how that all this study has initiated. The first 2 editions, performed in 87 and 1995, they were performed with questionnaires only. So we have no polysomnography, but we already had at that time a representative sample of 1,000 individuals from the city of São Paulo. We never performed these samples, the sampling methods by ourselves, but we always hired pooling companies, the most important ones in the country of Brazil, to assure we do have a representative sample. And in those 2 initial editions of EPISONO, we used the Unifesp sleep questionnaire. That's a very broad sleep questionnaire, not intended for diagnosis, but for populational screening of symptoms, sleep-related symptoms. As we had no polysomnography, we cannot think about diagnosis. And that was published. Most of the results were published in this single study in 2007. So you see there is this lag from the moment in which the studies were performed and when it was published. And that was because most of the initial aims of EPISONO were not for research purposes, but for public policy. So the first editions of EPISONO have resulted in changes in law, in public policy in the way the public sector deals with sleep treatment, sleep diagnosis, and things like that. So, and then this research focus has arrived from the 3rd edition on. But there is an important hallmark that was the main reason for performing the third edition. As I mentioned to you, the first two editions were performed with questionnaires only. And in this between, from the second edition in 87 to the third one in 27, we have the first prevalence studies of sleep apnea being published. And the most important one still nowadays is the one published by Terry Young at the New England Journal of Medicine, in which she published a prevalence of 4% of obstructive sleep apnea among men, and 4% among women. So let's say an overall prevalence of 4%. And here is the reason why we performed such a large trial. We had a sleep institute with 80 polysomnography beds, which were fully occupied every single night. And about 70 to 80% of these exams were due to obstructive sleep apnea suspicion. So it seemed, and this is very important from the perspective of epidemiology. So we have clinical observations guiding epidemiological studies. We had such a huge amount of inpatients coming to us looking for OSA diagnosis. So this very mild prevalence seems not feasible, but we only would be able to say that prevalence was unfeasible if we tested it, if we measured it. And this is the actual reason why the third edition of EPISONO was performed. So in 2007, we did our first epidemiology sleep study with polysomnographies, which means that, again, we hired a polling agency in Brazil that randomized a sample of 1,042 individuals from 20 to 80 years old, from socioeconomic class A to E, from every single corner of the city, and we brought them to the Sleep Institute, in which they underwent a polysomnography, full type 1 polysomnography, and every other complementary test and exam you can think of, which were available at that time. That includes actigraphy, that includes blood tests, that includes ambulatory blood pressure monitorment, and things like that. So EPISONO 2007 has resulted in more than 80 peer-reviewed articles so far, but let's go to the most important ones. And obviously, and we had this follow-up in 2015, in which we could, after 8 years, we could retrieve 67% of our sample, which is quite impressive, actually, considering that there is no follow-up in between. So 8 years of no contact, then contacting them back, and being able to retrieve 67% of them. So, as I mentioned, the actual reason for performing our first polysomnography-based population study was the prevalence of obstructive sleep apnea. And what did we got? We got the prevalence of 32.9%. And I have to say, at that time, I was not part of our group, but I can tell you the things I've been hearing from our research leaders, Dalva, Sergio, Monica, Leah, and all the people involved in EPISONO at that time, is that it was very hard to publish this data because basically that was a paradigm shift. Studies like EPISONO and a few others, more or less in the years of 2010 to 2015, a little bit earlier some, they were the first to publish prevalences of obstructive sleep apnea that were around 20 to 40%. And it was very hard to convince anyone who was not actually engaged in trials like that we should shift from a 4% to a 30-something%. But, and then we have this very usual finding that prevalence is higher in men and increases with age, which is actually very much expected. But you see that being an older man basically means that you have obstructive sleep apnea. But and then you have some more important data here. But let's go to our comparison with other trials, because the issue is that it was very hard from a study coming from a non-European, non-American country to publish such a paradigm-shifting article. We have to compare with other data that come after, which basically reinforced and corroborated with our findings. So probably the most important one, and one of the most recent, are the Hypno-Laus study published by Dr. Raphael Heinzer out of Lausanne, he actually reached a prevalence higher than ours, which you see there are a prevalence of 49.7 of a moderate to severe sleep apnea, which is quite high. We should say that this trial here was performed with not with full night type 1 in lab polysomnography. They had portable polysomnography, which might have overestimated the prevalence here. You should compare that. We reached a 30% considering since mild sleep apnea, since an apnea-hypopnea index of 5. So we see that in any case, we don't reach numbers as mild as the initial prevalence by Dr. Young, those of 4%. In order to sum up all these variability in the prevalence of sleep apnea, we have had a very interesting meta-analytical study by Dr. Adam Bangerfield, together with Dr. Atul Malhotra, the last author here, in which the prevalence of sleep apnea was summed up from every possible population-based study trying to diagnose or to measure the prevalence of sleep apnea. And basically what we saw is that the prevalence of obstructive sleep apnea might be as high as 45%. But since we're here talking about sleep epidemiology, we should always consider that epidemiology is not only the number, but the causes and the consequences of a disease. This 45% includes mild sleep apnea, which is always matter of debate in the sense of, should it be actually considered sleep apnea as a disease? Should it be treated? And if we consider only sleep apnea from moderate to severe levels, it would be not as high as 45% actually. We should say that very clearly. But again, in any case, it would be high and would be a very prevalent disease in any case. Considering this study from Bangerfield, you can see that Brazil is ranked as the second or the third country in number of obstructive sleep apnea patients. That's quite obvious considering that we also are the third to fifth country in terms of population and population density, but the conditions of our population in terms of obesity, in terms of prevalence of other diseases that are comorbid with sleep apnea, corroborate ourselves as Brazilians being ranked as second and third in terms of prevalence of apnea. So you can see here a heat map in which Bangerfield and colleagues have extrapolated the data from the available countries to the non-available one. And this is very interesting. You see that there are countries in which we do not have any epidemiological sleep study, but that we suppose they have a huge prevalence of sleep apnea, such as Pakistan, such as some East Asian countries, Southeastern Asian countries, and so on. But Brazil is always ranked very high in terms of obstructive sleep apnea. Going to the second most important, well, let's not say the second most important because it's not important, not interesting to have a ranking of importance among sleep disorders, but the second most prevalent sleep disorder in our trial, insomnia. What are our results regarding insomnia? We have reached a prevalence of 32% in what we try to call objective insomnia. So patients in which there were some polysomnography manifestations of insomnia. The actual prevalence of it was 15% according to the diagnostic criteria at that time. So 15% according to the DSM-4. So very consistent with other trials and studies all across the world. We also have had, now comparing the first 3 editions of EPISONO, a very consistent increase in insomnia complaints. You see that the complaints of sleep onset insomnia are increasing from 87 to 2007 very consistently in a very linear progression. You see that in the total sample among females and among males. And the complaints of early awakening symptoms that goes on a more geometric progression. You see, we have a exponential exponential curve. Why does that happen? Basically, from 1987 to 2007, so 3 decades, there are two issues that happen to the city of São Paulo. First, we're more and more stressed. We're working more and more. We're more and more concerned about our budget and salaries and working and things like that, because we're a very huge and cosmopolitan city. So that explains sleep onset insomnia, and that explains increasing the prevalence of anxiety and stress-related outcomes in the general sense. But why do early awakening symptoms have increased in a different pattern? Because there is an additional field here. The city of São Paulo in the last 3 decades has brought in about 5 million people. So people are living far from the city center, which means that they are commuting and taking more time to reach work, to reach any other place. Obviously, having to wake earlier for work-related tasks or for commuting is not a early awakening symptom of insomnia. But when you ask that to a patient, and most important, to a patient of a epidemiological trial, not a clinical patient, they might confound waking earlier due to insomnia symptoms and waking earlier due to a social need. So this is very important in our city. We cannot detach sleep medicine as a fully medical field from its social aspects. People do have sleep complaints and sleep disorders which are socially caused. Another important result we had is this finding that 39.2% of the city of São Paulo has complaints based here in the Epworth Sleepiness Scale, has complaints of excessive daytime sleepiness. And based on this finding, we try to use our epidemiological trial to reach some narcolepsy symptoms. Obviously, a epidemiological trial with only 1,000 individuals is not sufficient to estimate the prevalence of such a rare disease. But what we did here is to diagnose or to estimate the prevalence of dyads of symptoms. So excessive daytime sleepiness and every other major symptom of narcolepsy. So you see that people with excessive daytime sleepiness and cataplexy, we have almost 70% of the population with that. Sleepiness and sleep paralysis, 7.5%, and sleepiness and hallucinations, 4.7%. That is very overestimated by the fact that we were dealing with self-report. We had no objective measure of cataplexy, but a question in which we inquired our sample whether they have experienced a feeling of losing muscle tonus suddenly and things like that. So that's overestimated, but that's interesting in any case to see. This is actually a complaint in a considerable amount of our population. And to end things here in terms of our prevalence studies, we also have a very interesting study on the prevalence of bruxism, in which we reach a prevalence of more or less 5%. These are some of our studies. As I mentioned before, we have more than 80. And our idea now with the next edition of EPISONO is to draw the prevalence of every possible sleep disorder. Not every possible, certainly there are very rare diseases. We will not define the prevalence of Klein-Levin syndrome here, because that's very rare to be reached in 1,000 individuals. But the most prevalent one, we will be able to draw a precise prevalence and to follow up people that have these diseases with time. So as I mentioned, the 4th edition of EPISONO was performed in 2018 to 2019, and we are now about to release the first data of this edition. That was a bit delayed since the pandemic, and the pandemic really messed up with a few logistical issues with our trial. But I here would like to just call attention for our methods. So you all, the lecturers here, our audience, they can understand what will be released in a few weeks, probably, or even a few months. And we can actually think about collaborations using the data and the database of EPISONO, its 4th edition and every other edition, for partnering with researchers all across the world. So again, EPISONO, the 4th edition, was performed in a 4-stage, 3 to 4 stage sampling technique in a way to represent the sample of São Paulo in terms of socioeconomic status, gender, and age. And we had a polysomnography-based methodology, and also had several other tests and exams to have a very complete health profile of our sample. That was performed from August 2018 to June 2019, using all our rooms available. And we have had 4 stages. The first stage, that was planning the city to invite people to join in. Then we have the first stage in which our interviewers were to actually, the houses of the people that were polled, invited them to take part of the study. Then they were brought to the Sleep Institute for the polysomnography and all the other complementary tests. And finally, the 3rd phase was a second home-based phase in which we had actigraphy and some additional questionnaires. That was the actual schedule. So there was this home interview, then the polysomnography night at the second day. Actually, this interval might vary depending on the availability of our polysomnography beds and the availability of the patient. And then the polysomnography, blood pressure monitoring, actigraphy, Holter. Then after 12 days, we have the actigraphy return, and some sensing devices we were partnering with being returned as well. Within the Sleep Institute, what did we have? We had some photos of mouth and throat for anthropometric measurement of oropharyngeal perspectives for sleep apnea, blood pressure measurement, lots of questionnaires, tongue pressure measurement, a respiratory test we can discuss further, and the PSG. And by the morning, we have had some urine sample being collected, blood pressure, blood sample, spirometry, so we can separate other respiratory diseases from sleep apnea, which has been a critical point in other epidemiological trials. Breakfast, then setting up Holter and blood pressure monitoring, and specific tests for older adults, and then actigraphy. So you can see that that's a very comprehensive protocol. Here we have all the questionnaires you have. So the Unifesp one, we're still using the same questionnaire we used in 1987, which is outdated from a clinical perspective, but it is important to use the same in order to assure comparison along 4 decades. And basically every other validated sleep questionnaire is being used here. So in terms of behavior and condition, in terms of sleep in every sense, and related aspects. So we have had several other sleep questionnaires in order to draw the profile of São Paulo in terms of sleep and in terms of other disease that might be related to sleep. So here we have all the blood tests that have been performed. If you name a hormone, we have measured it. If you name a enzyme that has some important biochemical thing, we probably have measured it. So what was my point here? My point is first to address that I do think Brazil, with EPISONO and also with the other epidemiological sleep trials you will hear in a moment, ELSA and BioPND mostly, we have did a great job in order to bring Brazil into the map of sleep epidemiology. But what I can offer now, since we have this 4th edition and we have a database with data since 87, we are looking for opportunities to partner with and collaborate with researchers who can help us to extract the best of our data. So if any researcher have an idea that might be achieved by database, we are available to hear and to partner with. So with that, I just want to thank you all, and I will hand now over to our second lecture related to EPISONO, which I guess is from our professor Dalva Poyares. Thank you very much.
Thank you, Gabriel. I will share my screen.
Professora, a senhora parou o compartilhamento.
Now you can
agora
see
sim.
Right. So, oops, sorry. Perfect. So, hello everyone, it's me again, and I will speak in these next minutes on insomnia and excessive daytime sleepiness. Those are my potential conflict of interest. And I will speak again. We'll start with this issue of the high prevalence of insomnia. This is, as Gabriel has just presented, 15% of chronic insomnia in São Paulo City, and the issue of the duration is we found a mean duration of 12.2 years, and but this standard deviation is really high. And this is Charles Mohan's group, and he found a 1 year incidence between 7 to 15%, 1 year persistence between 6, ranging from 56 to 76, and mean duration of 3 years, which more in agreement with other studies. However, the duration, we found, for instance, 12 years. However, there is a limitation in our study, not only being cross-sectional data, but also we don't know the course of insomnia, whether they had a persistent insomnia or intermittent or any other type of evolution. Classic risk factors in many studies, in these international studies, for having insomnia are mood disorders, anxiety disorders, psychotic disorders, and also substance use disorders. In our study, in EPISONO, we found 4 times more chance to present any psychiatric symptoms. So these are, here you can see the odds ratio for having any psychiatric symptom. So, but also, all studies agree somehow that being women, older, and more recently belonging to the workforce, belonging to the low socioeconomic status, and also being retired, inactive, or widow. Apparently, there is a paradox between this and this risk factor. However, these are different stressors, and it has been reported along some studies. As Gabriel just mentioned, the sleep insomnia complaints, we are not speaking about insomnia disorder here, is only insomnia complaints. It's increasing every decade. However, I like to draw the attention to difficulty maintaining sleep. This is almost twice as much. And it's many studies also report that difficulty maintaining sleep is the most frequent insomnia complaint in the general population. With regards to hospitalizations and or demand for emergency service, our group, a study of our group showed that belonging to a female gender, aging over 40 years old, having insomnia disorder, and having presenting an apnea-hypopnea index over 15, meaning moderate to severe obstructive sleep apnea, are significantly associated with hospitalizations and/or demand for emergency service. Among good sleepers, only 5% is searching for health service, overall health service. Among insomnia symptoms, 11%, and among insomnia disorders participants, 21%. This is this recent study from Strand and several collaborators in Europe showing that you can see here every 1,000 participants from the general population, then you can see the number of people searching for, visiting a pharmacy, visiting a primary care physician, and being treated and diagnosed in primary health care, and also a small portion being hospitalized among insomniacs. And along with this data from Iceland, showing that people from the general population who are using hypnotics, 85% of had at least 2 medical disorders. This study was controlled by depression and anxiety. So we are speaking about medical disorders. Then this calls the attention for comorbid insomnia. Insomnia as a comorbidity or the medical disorder as comorbidity. Then we should pay attention to multimorbidity and sleep disorders and hypnotic use and also polypharmacy. This study also shows similar results. Here in the left column, we can see all those diverse types of medical disease, medical conditions, and here it's clear to see people with insomnia and non-insomnia. Insomnia is significantly more frequent among people with medical conditions. And here on the right side, the significant odds ratio of having insomnia if you have one medical condition. Then the study of Strand and colleagues discuss the importance of enabling general practitioners and family medicine practitioners to diagnose and treat chronic insomnia, on how to screen patients with insomnia and to identify those at risk, how to identify other concurrent sleep disorders, to share with the patient the treatment plan, valuing the patient's values, to be trained and aware of when to refer the patient to a sleep specialist, tertiary care. Moving to cardiovascular consequence of insomnia, or cardiovascular comorbidities, since many of the studies are cross-sectional, it's difficult to draw conclusions on causality. Compared with good sleepers, we found in our study twofold high risk of hypertension. This is the odds ratios of having insomnia and having hypertension. This is a meta-analysis that came out a year ago, showing that insomnia is there is a modest risk for insomnia participants to develop hypertension, and this was significant. This is an interesting study also, evaluated this cohort, and they demonstrated that having difficulty maintaining sleep and being a woman, this is associated with high risk of having coronary artery disease. We are speaking about myocardial infarction among women. It's a modest risk, but it's significant risk among those who had difficulty maintaining sleep, but not they did not find similar risk among male participants. This is the number of women who participate of this study. This is the significant hazard ratio for myocardial infarction. This is the famous study of the Penn cohort from Pennsylvania, and showing that sleeping lower than 6 hours and having insomnia is significantly associated with mortality. And then even when they had at baseline hypertension or diabetes status. But this meta-analysis that came out on Circulation Journal demonstrated that difficulty initiating sleep is significantly associated with mortality from all causes, but not maintaining sleep, and this among men. And we may wonder whether this consequence, either cardiovascular or mortality, differ according to gender and also according to social status. Here, this is still speaking about mortality. This study shows that having persistent insomnia is associated with high risk of mortality, of survival. This is the follow-up in years, and this is the cumulative survival curve. And when you see here, the persistent insomnia, even with taking and not taking hypnotics, is significantly associated with all-cause mortality. However, this late meta-analysis came out years later, showed no significant, meaning there is insufficient evidence to support an association between mortality and frequent or ongoing insomnia. We may wonder many reasons for this lack of significance, but we acknowledge that the insomnia criteria was sort of heterogeneous among studies. This is one of the potential explanations for this lack of significance. And speaking about the risk of suicide among insomniacs, we can see here high risk of suicide among insomniacs compared with non-insomnia. And on the right side, we can also see that low socioeconomic status, living in huge cities, metropolis, also having a diagnosis of drug and alcohol dependence and having mental disorders are also associated with more suicide among patients with insomnia. Overall, these are a summary of the consequence of untreated or prolonged insomnia reported in the literature, disregarded with the significance or effect size. Hypertension, in the general population, hypertension, stroke, heart disease, diabetes, other physical or mental illnesses, and among older adults, development of dementia, cognitive impairment, memory difficulties, and depression. So having this overview of consequences and prevalence, it's likely that insomnia may cost a lot may have a high cost, not only for the society, but also for the individual and for the employer. Here, you can see the numbers of insomnia costs per year. Total costs, health system costs, employer costs, and employee costs. However, all these results and data goes in the direction of how can we prevent, though? And there are some studies ongoing and some published speaking about sleep reactivity. Some people with this sleep reactivity, and if we recognize that soon enough, can we prevent? Is there a real window for prevention? How can we prevent the development of hyperarousal and of persistent and of chronic insomnia? So these are one direction for current and future studies. Moving to excessive daytime sleepiness. This is perhaps the first study of our group, and which is an interesting study. And the results showed a novel association between this allele and this genetic result, and a decreased likelihood of presenting with excessive daytime sleepiness. And the study was controlled for covariates and also ancestry. So this is the odds ratio, and there was significant of presenting this genetic alteration and the decreased risk of being sleepy. Then the conclusion is that this novel genetic association with sleep is now found, and we need to see or to prospect whether this can be found in other general population or in other different population. We are now writing and finishing analyzing these studies, unpublished data, and it's from the first author is Erica Treptow, and she is my postdoc student, and the rationale is. In short, is that excessive daytime sleepiness metrics have been criticized in the literature due to lack of association with sleep disorder severity or with disagreement with objective measures, such as multiple latency tests, wakefulness maintenance tests, and so on. But the Epworth Sleepiness Scale that many of you are aware is a widely used questionnaire to evaluate EDS. However, it may not be accurate as a sole measure to identify cases of somnolence in the general population. Then the study objective is to investigate the association between EDS, excessive daytime sleepiness, with social demographic, body composition, and polysomnographic measures in the general population of São Paulo, Brazil. We performed preliminary factorial analysis and confirmatory analysis, and we found 5 significant factors. The first one is quality of life is associated with EDS, fatigue, polysomnographic sleep duration variables such as sleep efficiency, wake after sleep onset, and total time awake. Factor 4 is arousal index and N1 and N3 duration, meaning some superficial and N3 being slow wave sleep, more deep sleep stage duration are also associated. And then finally, the BMI, body mass index, is associated. But the question is, obstructive sleep apnea, insomnia, and periodic leg movements are not associated with excessive daytime sleepiness when measured by Epworth Sleepiness Scale in the general population. Then we may conclude that EDS, or the results suggest that EDS measured by ESS, Epworth Sleepiness Scale, was associated with domains other than clear sleep disorders in the general population. It's not the clinical population. And Epworth Sleepiness Scale metrics was significantly associated with fatigue and sleep duration in the general population. I would like to finish this brief presentation. I brought some, I did not bring many data on pharmacological data because we are going to the goal is to speak more about sleep epidemiology. And then I'd like to finish with this slide that was presented on the BBC News, which is called the Global Sleep Crisis. And it was associated with the association of wake and sleep times with sleep duration. And results show that we, the Brazilians, the Japanese, and people from Singapore are among those who sleep less in the world. So then I finished with this red flag for the Brazilians. Shall we sleep more? Shall we increase our sleep time? Thank you for your attention, and I leave you to Gabriel to call the next speaker.
Very nice, Professor Dalva. So now, as the last talk in this roundtable about the EPISONO trial and our related studies, I'll bring in our colleague, Dr. Sergio Tufik, for a lecture about sleep disorder breathing and upper airway resistance syndrome in our EPISONO cohort. So that's with you now, Sergio.
Thank you very much, Gabriel. It's a pleasure to be here with everyone. I'm not sure if my slides are on right now. Oh, now I can see them. Thank you very much. So I'm going to discuss a little bit about the data from my PhD thesis. Just as a warning, I will go through a lot of data, but I'll try to focus on the main findings of this study. So don't really be nervous about the amount of data that I'm going to be presenting today, but I suppose they are all very exciting and yeah, very happy to share with you. So first of all, as an introduction, I would like to point out that in a study made in Brazil, 63% of the whole country population says that they have any symptom related to sleep. And among those, the most important one is symptoms related to sleep disorder breathing, which represent 35% of all the complaints. And mainly it's snoring and difficulty to breathe during sleep. So Gabriel said a lot about this in his presentation, but just to make sure that we all are in the same page, we saw a big increase of prevalence regarding to sleep disorder breathing, especially OSA, among these years. And just to clarify, we use here the definition of obstructive sleep apnea as an AIH of, AHI, here is this in Portuguese, between 5 and 15 events per hour plus symptoms, or with a AHI of 15 or more, we don't even need to consider symptoms in order to diagnose a patient with obstructive sleep apnea. And we divide them into mild, moderate, and severe based on the index. And as Gabriel also said, we have some few important epidemiological studies, but just to name the ones he said, we had the 1993 study of Terry Young with a prevalence of 2% in women and 4% in men. And then in 2007, the EPISONO study showed a prevalence of 26.1% in women and 40.6% in men. And the Hypnoallow study in Switzerland in 2013 shows a prevalence of 23.3%, 4% in women and 49.7% in men. And very interesting, we can see that the prevalence increases with age. So in the age group of people from 20 to 29 years, we see a prevalence of 7.4%. And you can all see a dramatic increase that we can see until the age group of 70 to 80 years old, with an average of 86.9%. And this results in the average total population of 32.9% that Gabriel said in his presentation. But it's very interesting to see what a huge increase we can see in the population as people get older. And interestingly, we also would like to talk. I would also like to talk about upper airways resistance syndrome. This is a very debatable disorder. A lot of researchers doesn't even agree that this is a disorder but Guillermo started pointing out upper airways resistance syndrome as a condition in 1993, especially because of patients with daytime sleepiness, but with no criteria to be diagnosed as obstructive sleep apnea. But what we could see was a slight limitation in their airflow, such as represented in this graph. And we could also see that usually this obstructed airflow was related with an arousal event. And in the epidemiologic study of 2007, we have prevalence of upper airway resistance syndrome. And we can see that very differently from obstructive sleep apnea, the prevalence starts very high with almost 31% in an age group from 20 to 29, but decreases very significantly also with to a 0% prevalence in the age group of 70 to 80 years old. And that's why we wanted to understand a little bit better what was happening with upper airways resistance syndrome patients. Were they getting better, or were they evolving into obstructive sleep apnea? As we could see, those two inverse triangles seems to suggest that people with upper airways resistance syndrome were evolving into obstructive sleep apnea. And that was the main idea of my PhD thesis, to really understand what was going on with sleep breathing disorders in general, especially if upper airway resistance syndrome would evolve into time to obstructive sleep apnea. And also if obstructive sleep apnea were getting worse with time. I'm not gonna go into details about the EPISONO study. Gabriel already said about it. But just to point out that I'm going to look the data of the 2007 study and the follow-up study, which happened 8 years later, to see what happened with those initial subjects. And we had almost 70% of their original subjects to evaluate. So I think it's an interesting amount of people. So from the 1,042 subjects that we used to have, only 876 had all the data we need in order to do this study. And 571 of those came back in 2015 for the follow-up study. And here is how these patients were divided in terms of their diagnosis criteria. A big part of the subjects had obstructive sleep apnea in 2007. Some of them had upper airways resistance syndromes, and some of them did not present any of the symptoms that we classified them. I'm not going to get into so much detail right now, because I'll discuss a little bit about the diagnosis criteria for upper airways resistance syndrome. So these were the criteria that we used in terms of airflow limitation, oxygen saturation, and finally symptoms. So in total, we consider 3 times 3 times 3, so 27 different diagnosis criteria, but some of them had a different cutoff for oxygen saturation. So in total, we have 45 different diagnosis criteria that we try to understand upper airways resistance syndrome. So again, airflow limitation, saturation of hemoglobin. We considered minimum, saturation, average, and another category that did not use this parameter at all. And when we were looking into the minimum or average, we considered both 90% and 92% cutoffs for a minimum and average SpO2. And finally, in terms of symptoms, we consider people regardless of their symptoms, or in terms of their daytime symptoms as sleepiness, for example, and a third category with a more broad range of symptoms. And just to see what these parameters influence in the prevalence that we found, so these are the prevalence found for each diagnosis criteria. I know it's a lot of things, but just to point out, the lowest one was 0.1% of the population. And this happened when we had a higher airflow limitation with an average saturation equal or above 92%. And the highest prevalence we found was in patients considering an airflow limitation of 5% or more, and did not taking into consideration hemoglobin saturation or any symptom. And in this case, we found a prevalence of 5.3%. Just to have a general idea of what happens with prevalence, if we consider higher percentages of airflow limitation, we have progressively less smaller prevalences. So I think that's something obvious to be considered. The other thing is when we talk about symptoms, if we use daytime symptoms is where we found the lowest prevalences. And you can see that they are very similar if we consider general symptoms, which is a very wide range of symptoms, including daytime, but also other things, such as nighttime symptoms related to upper airways resistance syndrome. And you can see that these numbers are very similar. So this makes us feel that patients with upper airways resistance syndrome tend to be present a lot of symptoms. And finally, in terms of hemoglobin saturation, I would say that changing these parameters or even not using this parameter at all did not change very much the prevalence that we found. So we tend to consider the lowest airflow limitation in order to understand upper airways resistance syndrome, since even those patients have a lot of symptoms. So just talking about age groups, we can see that the prevalence, as mentioned before, decreases with age. And in terms of BMI, we can see that it also decreases as BMI increases. So it has an inverse relationship. And this is the upper airways resistance syndrome of 2015. I will excuse, but I will not be able to present this data because of our time. But I would like to present what we found in terms of obstructive sleep apnea. And it's very interesting because the results are completely different from upper airways resistance syndrome. So first of all, in terms of gender, we can see that we have male prevalence, while for upper airways resistance syndrome, females were more symptomatic. In terms of age group, we can see that the prevalence increased with age. And finally, in terms of BMI, we can also see that the prevalence of obstructive sleep apnea increased with BMI. So that's another important consideration we have to do. The characteristics of people with upper airways resistance syndrome is very different from people with obstructive sleep apnea. So obstructive sleep apnea is more prevalent in men than increases with age and increases with BMI. On the other hand, upper airways resistance syndrome is more prevalent in female, more prevalent in younger people, and more prevalent with people with lower BMI. So everything is very, very different. And just to see how these subjects with upper airways resistance syndrome progressed with time. So finally, just comparing them with people without any criteria for sleep breathing disorders at all. People with upper airways resistance syndrome had different BMIs, different gender, and different sleepiness, fatigue, anxiety, and depression scales, meaning that they really present a lot of symptoms. And I think this is one of the most interesting parts, how these subjects evolve in time to obstructive sleep apnea. So you can see that controls also evolved into obstructive sleep apnea. So these are people that were controls in 2007 and that became obstructive sleep apnea in 2015 or 8 years later. And you can see there were people that were control and evolved into obstructive sleep apnea. But in comparison with upper airways resistance syndrome, we have a much significant percentage of patients that evolved into obstructive sleep apnea. And we have found an increased risk of 5.4 times for a person with obstructive sleep apnea evolving into, with upper airways resistance syndrome evolving to obstructive sleep apnea. And if we control the model for age and gender, we found an increased risk of 11.75 times the risk. So you can see that it is very significant. And when we see of what happened to the patients with upper airways resistance syndrome, we can see that most of them either stayed as upper airways resistance syndrome or they evolved to obstructive sleep apnea. And this is just seeing what happened to those patients. And in terms of controls on the right side, we can see that a lot of patients also evolved to upper airways resistance syndrome and obstructive sleep apnea, but the majority remained as control. In other words, with no symptoms involved or criteria for any sleep breathing disorders or these others category that also did not qualify for any diagnostic criteria. And in terms of patients with upper airways resistance syndrome that went to other categories, I'm going to tell you what the other categories was. So 2 of them had increased airflow limitation, but did not meet the 92% of oxygen saturation parameter. 2 of them also met the criteria of airflow limitation, but didn't have any symptoms. And 1 of them had a hypopnea index of 5 events, but didn't present symptoms also. So that's why they didn't qualify for obstructive sleep apnea. So as you can see, all of the patients had their sleep disorder breathing worse in time. So this was a very significant finding that all of them got their airflow related parameters worsening. And in terms of airflow limitation, we also saw that those patients had an increase from 10% of total sleep time to 33% of total sleep time of airflow limitation, really showing that airflow limitation got worse even in the patients that did not qualify for OSA or upper airways resistance syndrome. And we can see that comparing these patients with controls, they had a higher average hypopnea index in 2015. And comparing sleepiness, fatigue scale, depression scale, and anxiety scales, we can see that they did not progress a lot in the 8 years, but they really differed from the control group. And just to quickly mention what happened with obstructive sleep apnea, we can see here the prevalence we found in 2007. So 37% of people with obstructive sleep apnea became 57.8%. So you can see there is a very significant progression from patients with obstructive sleep apnea also. So just to briefly mention some of the main findings of this study, first to say that upper airways resistance syndrome really seems to be a disorder, and we found some very interesting characteristics. And even with a airflow limitation of 5% of total sleep time, there were a lot of symptoms and consequences involved. In terms of prevalence, we found a prevalence of 5.3% in the general population of São Paulo in 2007. We could see that all of the patients with upper airways resistance syndrome evolved with the worsening of their airflow parameters. We also saw that patients with obstructive sleep apnea had their disorder getting worse in the 8 years. And finally, mentioning the differences between the phenotypes from upper airways resistance syndrome patients when compared to obstructive sleep apnea. And with that, I would like to finish my presentation. Thanks, Gabriel, for the invite, and all of you for the attention.
Very nice. That was a very interesting presentation by Dr. Sergio. And with that, we close our roundtable, the second one. I guess we have a few questions for mainly Dalva and I. So we will just quickly discuss that and moving into the next one. Just reminding anyone in our audience that we still taking a look constantly to our YouTube chat. So the first question, I think, goes to, that's more a comment than a question, from our colleague Walter Silva, a dentist from the state of São Paulo, who mentioned that he liked that approach to evaluate the symptoms of narcolepsy when we are not able to estimate its prevalence. And indeed, a study like that with 1,000 individuals is more than sufficient to estimate the prevalence of sleep apnea, but not sufficient to estimate the prevalence of a rare disease. Like, by the estimate prevalence of narcolepsy, it's completely normal that in a sample of 1,000 individuals, we won't find a single one with narcolepsy by the normal prevalence. And in case of rare diseases, many cases, we have to have a different approach for prevalence. Rather than going to population-based samples, we have to go to the reference centers, assuming that people with narcolepsy go to these reference centers. But again, from a very critical epidemiological perspective, it's very hard to estimate the prevalence of narcolepsy. But again, we haven't the prevalence. We have the association of self-reported symptoms, which is very, very far from the actual prevalence, but still interesting to address the whole thing. Then we have our colleague, Denise Hazuk, who is a psychiatrist from the psychiatry department here at the Federal University of São Paulo. And he asked us about the relationship of awakening insomnia and depression, and whether we have findings on these regards. So I guess I would hand over to Professor Dalva to discuss a little bit about early awakening insomnia and depression.
Thank you, Denise, for your question. And I also like to hear from all the experts here, Dr. Ohayon and Dr. Malcolm. Actually, there are sufficient evidence showing that one study from Ohayon showed that depression, insomnia, comes before the first episode of depression in around 41% of the cases. So insomnia precedes depression in around 41% of the cases. And yes, there are many overlap symptoms. Similarly to OSA, many people with obstructive sleep apnea are first diagnosed as having depression symptoms. Depression is more frequent among people who are diagnosed with a given sleep disorder. And for the with regard to in terms of PSG, polysomnographic changes, the classic is the exchange between REM sleep and slow wave sleep. REM sleep is occurring earlier. REM sleep latency is shorter, and the highest period of REM sleep usually occurs in the second half of the night, and is now occurring in the first half of the night. And of course, slow wave sleep is also displayed. These are classical PSG changes in people with a major depression. And I think there was anything else, Gabriel? PSG?
Yeah. We do have another question by Dr. Denise.
No, I mean from depression, and I like to, if we have time, I like also to hear from Dr. Ohayon and Dr. Malcolm, because they are experts too. I think it would add to our discussion. You know, depression and insomnia is a really good, is a really relevant subject. Malcolm, do you want to add something to her question?
I can't even unmute. Thank you, Dalva. I think your answer was a really comprehensive one. I don't have anything particular to add for now.
Maurice, do you have any data on this relation that you'd like to disclose?
Okay, I found how to unmute. Sorry. No, I suppose that I would say, like Malcolm, that you have answered the question very clearly. Only a little remark about the possibility of insomnia and depression is that in all what was described in all the epidemiological study that I have heard this morning, one of the major concerns that I have is the differentiation between symptoms and disorder. Mm-hmm. Any kind of confusion between these two terms is really important to underline, because you see, insomnia can be a symptom, definitely, by per se. And it can be also a disorder when it's defined with a classification like the DSM-5 or the ICSD-3. The problem is a reference. So in all the epidemiological study, we must do like our duty to say every time to what we refer. If we are staying on the symptoms, we must stay on the symptoms and not regroup a constellation of symptoms, because otherwise everyone is lost, and what we give as prevalence or as frequency, and here also something very important, is that if you look in terms of prevalence, this question is irrelevant inside of insomnia and depression, because it's a frequency inside of depression. The term prevalence must be reserved to only the initial N that you have in your samples. So this is something that, again, must be underlined, or we will be all lost in translation. So this remark done, I will say that, yes, Dalva, the problem is the major problem is insomnia part of depression? And the answer is yes. Insomnia is part of depression. Does it mean that all insomnia are depression? No. Again, causality doesn't mean that you have the right to go in the two directions. So what was important was what just Dalva you said, and again is only to insist on that, is that first in depression we see insomnia coming like a premonitory or like a sign of something that will come. I see that we have something in the background coming, but
It's not a big deal.
Okay.
Don't
I
worry.
see. Yeah, sorry. I see in chat that Dr. Denise meant to question in particular with respect to sleep maintenance insomnia, and then to what extent that is to do with possibly, as Gabriel suggested, with the need for getting up early to commute, and actually that is a distinction issue that we are seeing as well in our rural study, similarly where we are not finding it easy to grasp whether the participants are understanding the question as if it's a voluntary or an involuntary early awakening. But of course, there are ways of probing that. I'm thinking particularly in the EPISONO study. Obviously, we bring them into the sleep lab. Do they still display this wake maintenance insomnia? Equally, if you use the Munich chronotype questionnaire, of course, you can see, do they sleep in the weekends? Are they able to do that?
Yeah.
Thank you, Malcolm. We will have time to discuss when we wrap up. And I like to raise again this point of early morning awake, because some analysis that Malcolm did with Laura Castro, and they are writing, and I'm just a co-author, and they are writing a very nice paper showing whether early morning awake can be a dubious performance when questioning to the general population. Thank you, Malcolm, for bringing this issue. And Gabriel, if you allow me, I also like to hear from Dr. Kallweit about the question on prevalence of narcolepsy and what type of... please.
Well, I think it's actually the work we are currently on to better understand the prevalence also of narcolepsy. Prevalence, again, as I may repeat what Maurice Ohayon has mentioned, prevalence for the disease, but of course we have with excessive sleepiness or maybe hypersomnolence a symptom which is much broader than the disease itself. And I agree to Gabriel what he said about his study.
Thank you.
Very nice.
Is there any other question?
There is another comment by Walter mentioning something about COMISA, this new phenotype. I don't know how to actually. COMISA seems more like the metabolic syndrome of within sleep medicine. So that's several different conditions that are brought together and worsens the scenario. And he just highlights that we should be considering all sleep disorders altogether instead of just looking for a particular sleep disorder within our patients. That's an important comment. So I guess that with these comments, we can move into the next roundtable, which is one that excites me really, because we have a lot of new epidemiological sleep studies going on in Brazil, and in different samples with different perspectives. And my real wish is that in some way we can in the future bring the perhaps the three major sleep epidemiological sleep studies all together in a kind of task force for epidemiology in Brazil. So we do have EPISONO, which we have already discussed. And the other two, which are just as fantastic as the previous one, are the BIPND cohort and the ELSA-Brasil cohort. So with that, we start our final roundtable, and I would like to bring in Dr. Malcolm von Schantz, that are joining us from Newcastle, from the Northumbria University, and he's dealing and fighting against jet lag and fighting against time zone issues to speak to us now. So thank you very much, Malcolm, and that's a pleasure to have you here.
Thank you very much. It is great to be here, and I've really enjoyed the session so far, and look forward to discussing with you briefly a very different sleep laboratory, which is a small town in the Brazilian heartland in the state of Minas Gerais. And this is actually, unlike EPISONO, this is not originally a sleep study. This is a study which was started in 2005 by investigators at the other impressive university in Sao Paulo city, the University of Sao Paulo, which is the state university, which was started by these two gentlemen, José Eduardo Krieger and Alexandre da Costa Pereira, in 2005. So essentially, it was begin as a cardiovascular study and has, of course, been continued as such. And we then had the opportunity to add to this observations on sleep and on circadian biology. So here are a couple of photos of this town. So it is, as you can imagine, a very different environment from what Dr. Gabriel described in the people living in the great metropolis of Sao Paulo, where people have issues of having to get up early for their commute. Here, they may have to get up early, but it's not to go on the bus for 2 hours, but it's in some instances to milk the cow. And it's also, even if you live in the town, because there are noises early in the morning, the dogs wake up, etc., etc. So the context of this little town is that it is a small rest stop on the so-called Royal Road, the Estrada Real, which connected the ports of Paraty at the coast with the mines in further inland in Minas Gerais, both gold mines and diamond mines. And for 400 years, there was a very intensive traffic up and down this road. You had an influx of forced labor of slaves being brought in from Africa, and then you also had flow in the other direction of the valuables, the gold and the minerals which were mined in the mines and brought down to the coast. And the little stop on this road was BIPND, and essentially it was a crucible, a mixing place for people from all sorts of different ethnic backgrounds. Whereas today it is a very peaceful and quiet place with a very limited inbound migration. And as sort of a result of this flux of people, you can see in the great admixture of a mixture of different ancestries in essentially all the individuals in our cohort in this town. So in this figure, each vertical line shows the genetic ancestry components of one individual. European ancestry is shown in blue, Native American ancestry is shown in red, and African ancestry is shown in green. So essentially, amongst the cohort, you have essentially one person whose ancestry is 100% European, one whose ancestry is nearly 100% African, and literally everybody else is a mixture of all the three other ancestral components. So features of this cohort also includes the as I already mentioned, a low inbound migration, a fairly conservative, fairly traditional lifestyle, which perhaps our grandparents would recognize very well. In the old individuals, there is a significant level of illiteracy. However, there is a high penetrance of electrification, so certainly everybody has access more or less to electrical light. And another feature of the study is that it is based around family pedigrees, which makes it possible to calculate heritability. And what I like so much about the study is that there is such diversity of data sets that we can correlate to each other. So we have the cardiovascular health outcomes, we have anatomical MRIs, we have multi-omic technologies, we have cognition and mental health data, we have circadian rhythm data, and we have sleep data. So essentially, this is kind of a summary of the data that we have related to sleep. So we have questionnaires on chronotype, sleep quality, and apnea. We have actigraphy. We have circadian phase measurements, DILMO, dim light melatonin onset. And we have an ongoing project where we are doing polysomnography in a very different environment in people's own homes. I just threw this slide in really quickly after having heard Dr. Gabriel's presentation. This is one of the earliest papers on sleep from this study before I joined the project. But essentially, it's showing that even with a cutoff of AHI about 5, 18.6% of the sample seems to have OSA. But what we see here is that this is a population which is where there's not a lot of obesity. The mean BMI is 25 kilograms per square meter. And also, you can see in the bottom, they use the family-based structure to calculate the heritability of sleep apnea, which they found to be 23%. Now, my first involvement of this study was when I did a sabbatical year at the University of Sao Paulo at INCOR, and we used the Horn-Östberg MEQ chronotype questionnaire. And you can see here the distribution of MEQ score between the low scores, which are night owls, vespertinus, and to the right, you have the high scores, which are the morning larks or matutinus. And you can see it's a fairly close to a normal distribution. But there's something going on, and you can see there's quite a strong shift towards morningness. In fact, it is such a strong shift that in this graph, which shows the well-known age-dependent increase in morningness, essentially we hit the top of this scale. The scale is not able to measure the morningness of these people because the questionnaire has not assumed the conditions that these people live in. And that becomes even clearer here, I think, where we're showing the BIPNG chronotype data in red, compared with two other data collections that we have, one from London, shown in blue, and one which Mario Pedrazzoli performed in Sao Paulo in green. And as you can see, the two metropolis have a chronotype distribution which is very much shifted towards eveningness compared to BIPNG, where the distribution pattern is about the same, but it is shifted towards greater morningness. Now, earlier this year, we used the family structure of this population to compare the heritability of different chronotype instruments. So we can do this because we have the different measures, both the Munich chronotype and the MEQ, which I just showed you, from the same individuals. And what we found was that the MEQ has a heritability, so that is the genetic component of the phenotypic variance, of about 37%. So, which is not quite similar to previously published data. The Munich chronotype questionnaire had a heritability of 32%. But what we found particularly interesting was just using a single question where people are simply asked to characterize their chronotype. Are you a evening type, morning type, definite, or moderate? And that is the one which has been used in many recent studies, particularly from the UK Biobank and also from 23andMe. And as you can see, even that single question of chronotype captures a large proportion of heritability. We then followed up by a study where we looked at circadian phase, so a physiological measurement. We looked at dim light melatonin onset, also known as DILMO. So our laboratory is a very different one. We don't have a big sleep center. This is just a small research station in the town center. And what we did was we brought groups of participants in the evenings, set them down in a dimly lit environment, took saliva samples every half hour, gave them snacks and drinks every half hour. And we called them DILMO parties because they enjoyed this. They were chatting, they were watching TV, and we were collecting saliva samples to look at their circadian phase. And essentially what we found was an early, as we had predicted, dim light melatonin onset. So the DILMO time is just after 8 in the evening. And shown on the upper panel to the right is the sleep onset during weekdays and 3 days, and the sleep offset also during weekdays and 3 days. You can see that they did sleep in a bit more in the weekends, but even in the weekends, the voluntary rise time is before 8 in the morning. And here you can see a image comparing the dim light melatonin onset time in our study, shown with a red dot, compared to other published studies, and showing how early it is. In fact, the only one which is even earlier is also from Brazil. It's from the study done by Claudia Moreno and colleagues at USP in rubber tappers in the Amazon rainforest, where they essentially have no or very little access to electricity. So they had an even early DILMO. Otherwise, all the published studies from populations have been later than what we observed. We also did a study where we used the availability of MRI data for showing anatomical brain structure. And I'm going to skip over this because I'm seeing time is going on. But essentially, we found an association between the MEQ score and a specific brain region, the anterior occipital sulcus. We did not find any association in the study with the Munich chronotype. But then I would like to move on to a few words about insomnia. Professor Dalva told us earlier about the joint analysis that we're doing. We're working on a paper where we're comparing insomnia data from this cohort and from the EPISONO cohort. But here I'm just going to show some of the data from the Biopenji cohort. So we were using the Insomnia Severity Index. We're trying to use that as a population-based screening instrument, which it is not designed for, had not previously been validated for until Laura Castro and Professor Dalva started using it, and the other colleagues at Unifesp started to use it. So we collected in Biopenji ISI data from 661 participants. So the ISI is a fairly simple questionnaire. It looks at different dimensions of insomnia with scores for the individual questions. And what we found in the Biopenji sample was actually, to our surprise, actually more insomnia in this quiet country setting than was observed in the metropolis of Sao Paulo. So 16% of the sample had ISI scores of 50 and above, which is suggestive of clinical insomnia. It was a higher score in women, and there was a correlation, as had previously been discussed, with shorter sleep, with more depression, and as you might imagine, with an evening chronotype. But again, the scale is designed for clinical screening, but we feel from these results that there is a utility of it as a population screening tool, even though, as has been previously discussed today, the latent meaning of some of the questions, especially those pertaining to sleep maintenance insomnia, may vary with different settings, different cultures, etc. So using these data, we were able to calculate the heritability of insomnia as measured by ISI score. The non-adjusted one was 24%, but adjusted, as we had to do, of course, for gender, age, education, as defined by years of schooling, and depression, we found a adjusted heritability of 19%. We then continued to take advantage of the available genome map data from the bioenergy cohort and do a so-called genome-wide association study, where essentially we do a simultaneous analysis of hundreds of thousands of genetic loci all across the entire genome, all tested against the same phenotypic measure, which is the ISI. And so this is called a Manhattan plot because it looks a bit like the Manhattan skyline. You see the human genome from chromosome 1 to chromosome 22, and each dot represents a single analysis point. And in one case, in one site, we did actually reach above the agreed significance point, and that is in chromosome 16. It was in a gene called CORO7, which encodes a protein which is expressed essentially everywhere, but particularly enriched in the thymus, but also in the brain. Even though it was just a single hit, we got sort of a cluster of associations significantly close to each other and a substantial beta coefficient. Of interest, perhaps, is that this gene, CORO7, was not in a recent paper, or two recent papers from the UK Biobank, looking at genome-wide associations of single question insomnia, but it has been associated with schizophrenia, interestingly, in other GWAS studies, again, tying it back perhaps to mental health. However, in a collaboration with the Unifesp group, we tried to replicate this in the EPISONO cohort, and we do not see this association, which can have different explanations, not necessarily meaning that this is not a real association, but of course that there are differences in population stratification, and also these are quite small samples for genome-wide association studies, less than 1,000 people, which is normally less than you need for seeing significance. So in closing, I would like to talk to you about the ongoing study we have now, which is led by Dr. Kristen Knudsen at Northwestern University in Chicago. So we have funding from the National Institutes of Health to do these home sleep recordings, home PSGs, for 2,000 people. So 2,000 members of this community or this cohort, and this is our protocol for this study, where we visit the participants' home in the evening. We take a blood sample, which we will be using both to look at RNA expression in blood cells and also metabolomics. We then hook them up for the polysomnography. We leave them to sleep alone, come back in the morning, take off the PSG setup, and then do anthropometrics, blood pressure, and another blood sample, both for RNA sequencing and also for metabolomics and for sort of standard analysis of lipids, glucose, insulin, and hemoglobin to look for diabetes. We do our best to leave these samplings 12 hours apart, more or less, so that we are sort of able to look at two antiphasic data points when it comes to circadian rhythmicity. So to summarize, we feel this is a cohort which is emblematic of the habit, the lifestyle, and also the genetic mixture of the Brazilian heartland. We have this rich tapestry of different phenotypes, including increasingly multiple levels of sleep data. And we also have the multi-omic data sets, the genome, the transcriptome, and the metabolome. And the study is now in its 16th year. So as we are starting to repeat some of the measures we've done previously, we sort of are collecting longitudinal data. And of course, we are simultaneously collecting information about the health outcomes in this population. And we are quite excited about the next few years, what it will teach us about the relationship about sleep and health in a way which can be partially specific to the context of this community where we're studying, but also, I think, very much addressable and applicable to populations in the rest of the world. And I think that's why the US National Institutes of Health were interested in funding this, because the genetic admixture, of course, is what is being seen to a growing extent in the United States as well. And sort of have an opportunity really to look at sleep and health in people of a multi-ethnic origin. So we have many people to thank for various aspects of this project, in particular Dr. Pereira and Professor Krieger, and Kristen Knudsen, who is leading the NIH project, and also many other colleagues, both in Brazil and in the United Kingdom, and colleagues at Unifesp with whom we have, as previously mentioned, collaborated on the Insomnia Severity Index, both in the comparison, which I haven't really talked much about, and in the genome-wide association study. And also our funding agencies from Brazil, from the United Kingdom, and also from the United States. So with that, I'd like to thank you for your attention. I'm very happy to discuss this here or elsewhere. These are my contact details.
Well, thank you very much, Dr. Malcolm. That was fantastic. And I couldn't like more the BioPND cohort design and results. They are fantastic. We have a question by Dr. Ulf, so feel free, Dr. Ulf.
Thank you very much for this really great and interesting lecture. I was wondering, there are some data also indicating that either temperature or maybe also air pressure can have an impact on some of these aspects you have addressed. Could you comment on this?
I think my only comment is it's not something I have considered sufficiently, but I think it is a very interesting point. I think and of course that applies to Sao Paulo as well, because Sao Paulo, of course, has a significant elevation. I think BioPND is about 800 meters. Yeah, I mean, you certainly have, if you look at the climate, given the latitude, which actually is the same southern latitude as Havana in the north, it is much cooler, certainly in the winter and certainly in the night. And yes, you could also have oxygen sort of pressure related aspects of it as well. So, very good point, which I'd like to think more about.
Well, we have seen this, thank you, in restless legs, for example. There are some data here. So thank you for considering this.
Very interesting. These environmental issues on sleep medicine should be more truly considered.
We should find a cohort in Bogota.
Certainly. Yeah, we actually have in South America several research groups in the countries in the Andes region. So Peru, Bolivia, and Ecuador. And they do have some interesting research on high altitude and sleep disorders there, which is a very specific condition. So yeah, very interesting. So I would like now to move to our last lecture, but reminding again to our people on YouTube, we are open for questions that we might address now or after this last lecture. And just to give a feedback to all our listeners and audience, we have had more than 50 listeners throughout the whole symposium, which is very nice for such a specific topic. So thank you very much for the audience. And I will ask our staff now to bring our last lecturer, Dr. Luciano Drager. He unfortunately have a conflicting commitment, so he left us with a pre-recorded lecture of his cohort, the ELSA cohort Brazil, which is a very nice and equally important epidemiological sleep study here in Brazil. So let's go for the next one. I'll just ask our staff to. There we go.
Hi, everyone. My name is Luciano Drager. I'm Associate Professor of Medicine at University of São Paulo, Brazil. I'm very glad to be involved in the Unifesp Stanford Sleep Epidemiology Symposium to present some data regarding the ELSA-Brasil cohort. This is a part of the roundtable to other epidemiology sleep studies in Brazil. This is my conflicts of interest. So the ELSA-Brasil study is an ongoing cohort study of civil servants from 6 different cities in Brazil, aiming to provide relevant information regarding the development and progression of clinical and subclinical cardiovascular diseases, as well as diabetes. So we involved adults from 35 to 74 years old at baseline to be involved in this ELSA-Brasil study. There are, as I said, 6 cities, 6 different cities, and São Paulo site is the main one. It's located in the Hospital Universitário at the University of São Paulo. And here we are performing all the sleep evaluation that I'm going to provide you some data about it. So just to make sure that ELSA-Brasil study is not like the EPISONO, that it's importantly the study devoted to detect the real prevalence of several disorders, several sleep disorders in the São Paulo city. But ELSA-Brasil study, it's more like Framingham or MESA that are trying to do association studies or longitudinal studies to check the impact of sleep disorders on several outcomes. So the rationale for developing ELSA-Brasil was based on gaps in the literature. So basically, sleep duration, everybody knows that most of the evidence addressing sleep duration is based on subjective data that, by the way, very simple, very pragmatic, feasible, etc. But of course, we have potential limitations because the huge amount of patients that have misperceptions about sleep. Other important gap that we need to discuss is that the vast majority of studies addressing OSA have not evaluated sleep duration or other sleep conditions like insomnia and vice versa. And this is a very important question because the coexistence of sleep disorders are common, as you know, for instance, COMISA, etc., but their potential consequences are largely unexplored. And with this background, we developed ELSA-Brasil to explore these associations in isolation and combining several sleep disorders. For monitoring sleep apnea, we decided for using our home sleep monitor. This is a traditional embleta. Everybody in this room knows this system, very pragmatic approach. As you can see here in this table, you can see in this screen, a participant with several events of hypopnea and apnea obstructive events over time, promoting intermittent hypoxia, the hallmark of obstructive sleep apnea for these patients. So in ELSA-Brasil, we are using a more stringent criteria for defining OSA. So basically, we are limiting to moderate to severe to capture probably the sleep apnea phenotype with more relevance in terms of OSA severity. So we score this OSA based on 2012 criteria. For monitoring sleep duration, we did both subjective and also objective sleep duration measurements using wrist actigraphy in a typical week of each participant. So this is also the screen from the ActuWatch 2 from Philips Esperonics, showing in blue the time that the wrist actigraphy detects sleep, and here we have a huge movement characteristic of the wakefulness during the 24 hours period. So just to figure out the amount of sleep, markers of sleep fragmentation, variation in the sleep duration beginning, and also variations trying to figure out the sleep irregularity markers. So the first phase, we call the first phase of ELSA-Brasil, is to explore cross-sectional studies. So figure out the association between sleep apnea, short sleep duration, insomnia, etc., on clinical outcomes, cardiometabolic or anxiety, depressive symptoms over time. And the first paper was published in CHEST in 2009. So initially invited in São Paulo city, more than 2,400 participants to perform the sleep evaluation. And after excluded some patients that refused to participate, polygraphy or actigraphy failure, predominant central sleep apnea, patients under previous OSA treatment, patients who using sedative drugs, shift works, etc., that may influence these main outcomes. We selected more than 2,000 to participate. In terms of obstructive sleep apnea, we found a huge frequency of OSA in ELSA-Brasil study. So basically, we have a third of these guys presented at least moderate to severe. This is very consistent with EPISONO and other recent cohorts around the world, showing that moderate to severe is much more common than expected, and this is probably related to the burden of overweight and obesity that is also present here in Brazil. Taking into the perspective of sleep duration and selecting patients that sleep less than 6 hours, that we call short sleep duration, we have around a quarter of them is sleeping less than 6 hours. So making this a very nice amount of participants to perform associations and to decide in future studies to evaluate the incidence of events based on this kind of sleep disorders. So in the CHEST study, we're starting to put the pieces together, trying to combine to figure out the associations of having OSA, sleep duration extremes, or both, in terms of several outcomes. So first of all, we found that half of participants had no OSA and slept higher than 6 hours. 22% of them had only OSA. 16% of them slept less than 6 hours but have no OSA, and 11% of the ELSA participants had both conditions. So this is an important one to figure out, again, the heterogeneity of these participants according to these two, only these two sleep disorders in this perspective. So this is the distribution of patients. In the blue is the total population, and in green and red is stratified according to the presence or absence of obstructive apnea. And as you can see here, most of the patients in the São Paulo city is sleeping 6 to 7 hours, and not the traditional 7 to 8 hours, as you can see here from this graphic. Around 4% of them is sleeping using objective measurements 6 to 7 hours, meaning that a huge amount of patients is sleeping less than 6 hours. This is a very impressive results. And on the other hand, it's quite rare to find participants sleeping that the usual sleeping is higher, equal or higher than 9 hours. As you can see here, just to figure out that obstructive sleep apnea usually sleep less than patients without obstructive sleep apnea, and we can discuss further the potential reasons for these results. So when you combine and trying to figure out the association of OSA, short sleep duration, and their interactions on some outcomes such as daytime sleepiness, anxiety, and depressive symptoms, what we found? We found that this already the adjusted odds ratio, we found that in terms of daytime sleepiness, short sleep duration, but not OSA, was independently associated with daytime sleepiness. Regarding anxiety and depressive symptoms, neither OSA or short sleep durations was independent associated with these outcomes in the ELSA-Brasil study. So this is an important one. When you look at the cardiovascular risk factor, including obesity, hypertension, type 2 diabetes, and dyslipidemia, what you found? The well-known association between obesity with obstructive sleep apnea, but look at that. Several guys said, well, short sleep duration is frequently associated with obesity, but here and other recent studies also using objective duration did not find any association with obesity regarding short sleep duration. We also found a significant association between obstructive sleep apnea and hypertension and dyslipidemia and the trend for type 2 diabetes. No independent association was related to short sleep durations regarding hypertension, type 2 diabetes, and dyslipidemia in our study. So this is the summary. What you found. So basically, OSA was independently associated with obesity, hypertension, dyslipidemia, trend for diabetes, but not to excessive daytime sleepiness or anxiety and depressive symptoms in this context. Looking in the OTEX in the perspective of short sleep duration, we found a positive association with excessive daytime sleepiness, a trend to obesity, but not to the other cardiovascular risk factors or anxiety of depressive symptoms. And no interactions was observed in this study when you combine OSA and short sleep duration. So this is a very good example how ELSA-Brasil is struggling to manage the different sleep disorders. It's very challenging, by the way, and trying to combine and try to figure out some phenotypes that is related to to higher risk regarding the outcome. So, as I said before, I'm not comfortable to still using subjective sleep duration based on our data and based on several data from MESA and other studies. And in parallel, we are observing a huge increase of technology monitoring sleep. Of course, there are plenty of room to improve this technology, but more and more, we have wearable devices that allow measurements, sleep duration, probably in the very best way than applying questionnaires. Including there are a lot of researchers like this one that wrote an editorial in Sleep Medicine, an open request to epidemiologists, please stop requiring self-reported sleep durations because of this low agreement and low correlations with objective measurements. Especially, as I said, when you have available actigraphy wearable device, despite the price, I know this is very cheap, very feasible, very pragmatic, using subjective sleep data. But here, I'm going to show you some pitfalls for using sleep duration. So first of all, we did this as a study in ELSA-Brasil. It was just published in Sleeping Briefing. This is in press, it's already in PubMed. By the way, I have a lot of challenging to publish this paper, probably because of reviewers that like this, again, subjective data. But we reproduced the data from several studies showing a poor correlation and a poor agreement between subjective versus objective sleep duration. This is not new, by the way, but here, the following slide, we presented some new data and just to show important message here. So based on in this low agreement and low correlations, we quantify the short and long sleep duration reclassification according to this criteria, calling short lower than 6, the reference group 6 to 8, and long sleep duration based on our distribution at least 8 hours. And as you can see here, only 41% of patients that self-reported lower than 6 hours of sleep by self-reported they agreed to the sleep actigraphy monitoring. The others, around 6%, were classified into the reference group or even into the long group. In contrast, only 12% of patients that initially classified by self-reported as having long sleep duration was confirmed by wrist actigraphy. Most of them were reclassified into the reference group, and the interesting one, almost 14% of them were reclassified into the short sleep duration group, so providing a lot of misperceptions about the real sleep time. So this is impressive one. This is impressive one. And then when we figure out the predictors of short sleep duration reclassification, we found that insomnia, being female, high sleep efficiency, low SO2 saturation, higher awake after sleep onset, and the higher number of awakening, in other words, markers of sleep fragmentations, were associated with this short sleep duration reclassification. In terms of the predictors of long sleep duration reclassification, interesting one, the presence of hypertension was associated with more than threefold chance to have a reclassification after reporting self-reported being long sleepers. And we also performed an analysis using 5 sleep report categories: less than 5, 5 to 6, 7 to 8, 8 to 9, and higher than 9, to figure out the overall categories of sleep durations. And we found that the more extreme is the sleep duration, the greater is the self-reported sleep duration reclassification. So this is a very, I think that's a very important result in terms of reflecting about the real utility of still using subjective sleep duration. More recently, we just published a paper in Sleep Epidemiology. By the way, congratulations for putting a new journal, a very important journal available for the sleep experts. So we published in Sleep Epidemiology a paper that described now sleep misperceptions, that we provided 2 concepts. Participants that underestimated sleep in at least 1 hour, less than 1 hour, when you compare subjective versus objective sleep durations, and participants that overestimate sleep in at least plus 1 hour, when you compare, again, subjective versus objective sleep duration. We found that in ELSA-Brasil, 61% of them were in the matched group, meaning that the difference between subjective and objective sleep duration is within 1 hour. So 61% fill this category. And the independent predictors of sleep duration match between subjective and objective sleep duration was marriage status, high education levels, and higher sleep efficiency. The other 40% of them or underestimate sleep duration or overestimation sleep duration, as you can see here, around 20% each. So we found the independent predictors like ethnic factors like black hair race, Asians, the presence of excessive daytime sleepiness, markers of sleep fragmentations, and insomnia for the underestimation patients. So independent predictors that we need to figure out, especially a subtype of participants that are most prone to have sleep misperceptions when you use subjective sleep durations. So now we are still performing several cross-section studies, but more slowly moving for evaluating longitudinal studies. We don't have hard outcomes yet in the ELSA-Brasil, but we're trying to explore some predictors, some surrogate markers of cardiovascular risk, and I'm going to show you just one example. So we are very glad to have the coronary calcium score available in São Paulo site in the ELSA-Brasil. So as you know, the coronary calcium score is a predictor of cardiovascular events over time, regardless of other traditional risk factors. And based on these important information as a prognostic factors, we are combining coronary calcium score with the presence of obstructive sleep apnea, daytime sleepiness, sleep duration, and the interactions regarding the incidence, the new cases of presence of a coronary calcium score. Again, this is important prognostic marker of cardiovascular disease. In this manuscript just submitted, and just provided here a very simple data, just because the limited time to present the data here. But as you can see here, this figure shows the incidence of CAC plus than 0. Again, new case of coronary calcium score positive, and stratified according to the presence of or absence of OSA and daytime sleepiness. So this is the group that had no OSA and no daytime sleepiness, only daytime sleepiness, only moderate to severe OSA, and the dark blue show patients with obstructive sleep apnea that also presented daytime sleepiness. And as you can see here, the incidence of CAC score was much more evidence in obstructive sleep apnea patients who were sleepy, probably suggesting this phenotype of higher risk in comparison to OSA patients with no daytime sleepiness and no daytime sleepiness. Daytime sleepiness only was not associated with increased coronary calcium score in comparison to the control group. So in the multivariate analysis, the presence of OSA and the sleep phenotype was independent associated with increased incidence of coronary calcium score, showing, trying to figure out some special phenotypes of cardiovascular risk in this scenario. So I'd like to conclude, and again, congratulations to the organizers for inviting me for the Unifesp Stanford Sleep Study Epidemiology Symposium, that the ELSA-Brasil cohort is intended to explore the impact of OSA, daytime sleepiness, sleep duration, and insomnia. We have growing some studies, ongoing studies on insomnia as well, in several consequences, mainly cardiometabolic, but not limited to. Based on the available technology and significant sleep misperceptions, it's time to reappraisal the use of subjective sleep duration. Again, I know the utility and how useful is to measuring, is to detecting by simple questions sleep durations, but probably this is not the best tool. As we observe in sleep questionnaires when they are screening obstructive sleep apnea, we have frequently need to use objective measurements like polygraphy or polysomnography. In future longitudinal studies may help to understand the burden of comorbid relevant sleep conditions, as I just briefly presented here. I'd like to thank all this the sleep team at the ELSA-Brasil, São Paulo site, Professor Tufik, Professor Isabella Ben-Senor, the Sleep Laboratory and the Heart Institute. I have a strong collaboration with Professor Geraldo Lorenzi, and all the Sleep Brazilian sleep team that we performed in the more than 2,000 sleep studies and follow up in these guys and try to generate all this data. Thank you so much for your attention.
Very nice. So this was our last presentation by Dr. Luciano Drager about the ELSA-Brasil study. And since I guess some questions have been answered before, I guess it's time to hand over the discussion for a final wrap-up and discussion to our chairs, Dr. Dalva Poyares and Dr. Maurice Ohayon.
So I'm afraid we are running out of time. We're supposed to finish 5 p.m. And I'm afraid that either Dr. Kallweit and Dr. Malcolm are, it's really late there. And I think I have to thank you all, me and Gabriel, And we thank you all for the nice presentation, and we hope that we could take many insights from these, such a diversity, not only related to the different cohorts, but related to different expertise that we were able to join today. I think the audience and me, myself, I'm very happy to hear from you all. And I hope we could collaborate, and I hope people in the audience, these presentations and these summary data we have discussed also encourage you all to come to the sleep field and to collaborate and to draw some collaborative studies. So it's really nice to participate in this. Maurice, would you like to say some final words?
Yes, final word. I think that it's time to finish this meeting because we are effectively in delay. I am very happy to have seen this meeting between Stanford and the Sleep Center in Brazil, in Sao Paulo, going. And I suppose that effectively, like you say, we had a lot of point of view on the general population, sleep studies inside. It's very interesting. And I hope that we will have the opportunity to have this kind of meeting another time. Thank you very much to all. And it was an honor to be with you, Dalva. You are on mute. You are on mute, Dalva.
Sorry. It happens. It happens quite often. It was our pleasure, and we again thank you all, Kallweit, yourself, Maurice Ohayon, and Dr. Malcolm, for joining us in Brazil, and also Luciano and Sergio Brasil and Gabriel. And we will need to finish the meeting, and we hope to be in touch in the near future. Gabriel, do you want to say something?
I just like to thank you all and thank to the audience because we have finished with almost 40 listeners, which is quite a lot after almost 4 hours of discussions. So congratulations to our listeners and thank you very much.
Thank you.
Thank you. Bye-bye.
Thank you. Thank you very much.
Bye-bye.
Bye-bye.
Thank you. Bye-bye.